Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Welcome to the Michigan Medicine Radiology Vault. My name is Renee Pinsky, and I'm going to discuss gynecomastia. I have no disclosures. Between birth and puberty, male and female breasts are identical. They are undifferentiated. Once puberty begins, that's where the differentiation occurs. In females, estrogen and progesterone production results in development of breast tissue with ducts, stroma, and lobule formation. In males, the presence of testosterone results in the relative atrophy of ducts and stroma, and the lack of progesterone introduction results in suppression of lobule formation. In the presence of increased estrogen with the resultant ductal and stromal development, pathologies that can occur include gynecomastia, pseudoangiomatous stromal hyperplasia, and malignant processes such as invasive ductal carcinoma in situ, and papillary neoplasms. In the absence of progesterone and resulting lobular suppression, it is very rare to have various pathologies such as fibroadenomas and phylloides tumors, as well as lobular neoplasia, ALH, and LCIS, and lobular cancers. Lobular cancers represent approximately 1.5% of all male breast cancers, whereas in women, lobular carcinoma represents approximately 15% of all female breast cancers. Clinical indications for imaging of the male breast include a palpable mass or thickening, pain on its own or associated with other symptoms, breast enlargement, nipple discharge, nipple retraction or skin changes, and screening. In 2018, the American College of Radiology issued the appropriateness criteria for evaluation of the symptomatic male breast in the Journal of American College of Radiology. The guidelines are to the left, but the summary is that if a male has a classic clinical signs and symptoms of gynecomastia, no imaging is necessary. However, if the man is under 25 years of age and the symptoms are not clearly specific for gynecomastia, it is reasonable to start with a breast ultrasound. If the male is over 25 years or older and has symptoms that need workup, it's reasonable to start with a mammogram and ultrasound to follow. Gynecomastia is far and away the most common diagnosis that a male will have when they present for evaluation of a breast mass, representing 85% of all such presentations. Less commonly, dermal lesions, fat-containing lesions, and other benign processes will fill out the list of possibilities for a male breast mass. It is much less common to have a breast malignancy with primary breast cancer or metastatic disease. The most common primary breast cancer is going to be invasive ductal carcinoma in a male. Gynecomastia is defined as excessive growth of breast tissue. In the clinical setting, it presents as unilateral symptoms such as a soft or firm palpable mass related to the nipple or thickening of the breast tissue. On imaging, more commonly it is bilateral and often asymmetric. It's important to note that there are no calcifications associated with gynecomastia on mammographic imaging, and there is no skin or nipple involvement. The pathophysiology of gynecomastia is the result of the alteration of testosterone and estrogen balance. So anything that increases the levels of estrogen in a male relative to the level of testosterone can result in gynecomastia. There are 3 peaks in incidence of gynecomastia. In the neonatal period, the gynecomastia is caused by the influence of maternal hormones, and this is typically transient and resolves in the first weeks or month of life. In adolescence, in the teenage boy from the age 13 to 18 and possibly extending up to the age of 22, gynecomastia is related to hormonal fluctuations of puberty. This can result in significant emotional distress related to breast formation, and it's important to reassure them that the gynecomastia is transient and typically resolves in just a few months or a few years. In the adult years, the common pathway for gynecomastia is a hormonal imbalance with many causes. Underlying medical conditions that can result in gynecomastia include cirrhosis, chronic renal disease, thyroid dysfunction, adrenal insufficiency, Klinefelter syndrome, hormone-producing testicular tumors, and others. There is a long list of medications and drugs that can cause gynecomastia, commonly diuretics such as spironolactone, exogenous estrogen given for various reasons, anabolic steroids, as well as psychiatric medications and alcohol use, as well as street drugs and more. So when it comes to imaging, what do we see? We can see a normal male breast. We can see pseudogynecomastia, which is also considered normal, gynecomastia, benign and malignant processes. Normal male breast, there is minimal retroareolar density, and the breast is predominantly composed of fat with some minimal stromal and ductal tissue. Lobular formation in men is exceedingly rare. These are images from a male with a BRCA2 mutation who was undergoing screening. This is another image of a normal male breast, predominantly fat, minimal stranding of stromal tissue, and prominent pectoralis muscle. In pseudogynecomastia, the complaint is breast enlargement, typically symmetric but not always, increased volume of the breasts, and otherwise the breasts appear normal. Typically this is associated with obesity where there's increased fat elsewhere in the body as well. The appearance of gynecomastia is variable. The images here demonstrate dendritic gynecomastia, an example of retroareolar density with fine extensions into the fat. It is typically centrally retroareolar and can extend into the upper outer quadrants. It usually blends into the surrounding fat, and so it's been given the name flame-shaped. And in general, this is the appearance when the gynecomastia has been present for more than 1 year. And on pathology, when a breast is looked at, the pathology is hyalinized stroma, giving the increased density that we see on the mammogram. These are images of a 90-year-old man who presented with left breast pain, and you can see that there is bilateral dendritic type gynecomastia with the retroareolar density and the flame-shaped interdigitation of the density into the surrounding fat. And you can also note that he had symptoms on his left side, but he actually had fairly symmetric gynecomastia on the right side, which was asymptomatic. Another form of gynecomastia is the nodular form, which presents as a mass-like structure immediately deep to the nipple with a posterior rounded contour. This is the earlier form of gynecomastia, which is less than 1 year. And on pathology, this is hyperplasia of the intraductal epithelium and edema of the stroma, and this typically presents as a painful mass. The third type of gynecomastia is the diffuse glandular type. Mammographically, this has the appearance of a heterogeneously dense female breast and is typically related to continuous exogenous estrogen administration. The ultrasound appearance of gynecomastia is that of a retroareolar hypoechoic structure with interdigitating hypoechoic tissue with the echogenic surrounding fat. There is no mass-like appearance of the hypoechoic tissue, and there is typically no vascularity associated with it. These are images of a mammogram from an 85-year-old with a palpable retroareolar breast mass. You can see the dense tissue in a retroareolar location with a convex margin with the appearance of a mass-like structure. Ultrasound was performed and demonstrated an irregularly shaped mass with both areas that appeared to have interdigitation with the surrounding fat tissue versus a more mass-like structure. These were imaging findings that were difficult to discern from cancer, and for that reason, biopsy was performed. This was biopsy-proven gynecomastia of the nodular form based on the imaging appearance. There are several paths to gynecomastia management. Reassurance that it is not cancer is very important. In teenagers, it is also important to reassure them that this will likely regress spontaneously before the age of 20. If it's felt to be medication-related, it's important to stop the offending agent if possible, and the symptoms will usually regress. If these factors are not successful, then medical therapy is available, including SERMs such as tamoxifen with effect at the estrogen receptor site. The aromatase inhibitors such as letrozole and androgens can be used as well. There are surgical options in extreme cases, including liposuction and excision. Distinguishing gynecomastia from breast cancer is critical, and it's important to remember several features of each, including that gynecomastia is very common. It's often tender, thickening, or mass-like structure behind the nipple. Gynecomastia is often bilateral on imaging with a density centered on the nipple, and there are no associated skin or nipple changes. Whereas male breast cancer is uncommon, it is typically painless, and very rarely is it bilateral. On imaging, the density can be eccentric to the nipple, and there can be associated skin and nipple changes, such as discharge, retraction, and thickening. Finally, I'd like to share two cases that demonstrate that not all retroareolar densities are gynecomastia. In this case, there was a palpable mass that corresponded to this dense retroareolar heterogeneous mass with spiculation of the posterior convex margin. On ultrasound, there is a hypoechoic heterogeneous, somewhat vertically oriented mass with internal vascular flow. This was an invasive ductal carcinoma and did not represent nodular gynecomastia. These are images of a 44-year-old male with a palpable mass, and my question is, why is this not gynecomastia? The presence of nipple retraction on the mammogram and the mass in a retroareolar location with internal vascular flow are features which should indicate that this does not represent nodular gynecomastia. Gynecomastia should have the classic imaging and clinical features, but if it does not, then biopsy can be performed. In summary, gynecomastia is the most common cause for a referral for male breast imaging. The most common clinical scenario is that of a tender mass or thickening deep to the nipple. There are numerous causes which are linked to an imbalance of estrogen and testosterone. It is important in imaging to distinguish from breast cancer, and if you are unsure, then biopsy can be performed. Expectant medical and surgical management options are available. Thank you for your attention.